Fantastic. Welcome back, Wayne. We haven't seen you for a while. There are a lot of new faces in the room, and we have an amazing program coming together today. I think that because there are a lot of new faces in the room, for this particular meeting, I know that it's been incredibly difficult to park, and so we will have many of the people who are signed up but are not yet in the room rolling in a bit late. But I think it would be helpful if we could just quickly go around the room and say your name and your organization, and then just keep going so we get to know each other's names and faces, and then we'll launch into this magnificent program that we're going to hear about from Dr. Earl. So, Joe.
Hi, good afternoon. My name is Joe. I'm from VA Home Telehealth.
And just, if you could be as loud as possible, we don't have a mic to pass around.
I'm Bob Trine. I've been a volunteer with California RightCare for a number of years, and I have a service corporation and a product corporation focused on genomics.
My name is Chris Stewart. I'm here with Kaiser Permanente.
Neil Kaufman, Canary Health.
Frank Federico, Health Meds Medical Director.
Robin St. McBride, HealthNet.
Donna Lieberman, American Diabetes Association.
Jeff Keats, Nova Nordisk.
Angela Jimbrone, Andrew Consulting.
Susan Schuler, I'm
Beth Grivet, also here with you.
Wayne Chen, Medical Director with Blue Shield.
Scott Glenn, Blue Shield. G. Evans, Consultant.
Lisa Stark, Partners Medical Group. Jennifer Neff, Grander Ingelheim. Chloe Bird, Rand Corporation.
John Leung, Novartis.
Fred Bergson, also Novartis.
Kaylee New, Amarin.
UCLA.
My name is Janine Morrison. I work for the LA County Department of Public Health. I'm also a primary care provider.
Earl, so with the VA, also have ties to Allegheny USC.
Alan Fremont, Grand Corporation.
Carol Zaire, Medical Director of HealthNet.
Carol Eden, Tech Medicine of USC.
I'm Hattie Hanley. I'm Director of the Right Care Initiative. Oh, and we didn't hear from Shawnee Smith of the American Heart Association. Great to have you with us today. Thank you. Well, the parking was very tricky today. So I just want to thank you for coming from the four winds once again to gather for this very important work to spread best practices. And I want to say that it's a very special full circle moment for me thinking about having this Veterans Administration presentation, because at our very first RightCare meeting in San Diego in February of 2011, where we started the experiment of gathering the health systems in one region to adopt and spread best practices for the specific purpose of preventing and better managing heart attacks, strokes, diabetes, and now heart failure. We had Bob Smith from the VA as one of our very first presenters, and one of the reasons we started with our NIH grant in San Diego is because of the very important work that's being done by the Navy and the Veterans Administration in the San Diego region. So it's wonderful to have across all of our communities, actually 3 out of our 4 communities that we've started, it's wonderful to have the military and the VA with us at the table in this public-private partnership. I also want to point out that today we have with us Janina Morrison from LA County Public Health, and Tony Kuo, the Chronic Disease Medical Director for LA County Public Health, apologizes that he can't be here. However, he has arranged for, collaborated with RightCare to get a small grant from the Centers for Disease Control that will enable a bit of support for our work here. And part of that support will be through a contract with Bob Trine who has been a RightCare enthusiast statewide. He and his wife Lynn have been coming and listening to these best practices around the state. And Bob has taken his very important experience with Gunderson Healthcare, one of the top health systems in the country, and done some cross-pollinization, bringing Gunderson out to us. And that's part of how we really got going on our blood pressure work. That they were, at the time that they presented to us in Sacramento, they were the top performer in the nation on blood pressure control. And granted, it is a very different environment in Wisconsin where Gunderson works, but they really brought us down to earth about this not being such a difficult task, getting blood pressure under control. And they brought a stack of pocket cards, hypertension pocket cards, which they used to have, to encourage their system to get to top performance on that. We then had our group up in Sacramento create another card through a collaborative process with the Medi-Cal program. And those cards were created using JNC guidelines. Now, a new version of the cards has just been created and printed by the California Department of Public Health and is being distributed very broadly. So that was a wonderful cross-pollinization that is increasingly happening, not just across our communities in California, but also in other states, and even a bit internationally. So I want to just mention that several of us will be at an invitation-only technical meeting on hypertension control and creating a national action plan for getting 80% of the public to goal for hypertension by 2022 at CDC in Atlanta, the second Monday and Tuesday of September. So that's a wonderful a moment for RightCare. So one of the important things is that our leaders are leaders in multiple communities, not just, everyone here at the table here in LA has extensive other networks that they're pollinating this information to. So what we learned from Earl today, we will be spreading to other places as well. And hopefully we'll have him present at some of our other communities. So I just want to say that, just to give you a little planning information for the future, while we have a full set of folks at the table, while we try to meet here on the third Thursday of the month, as you noticed when you tried to park here today, this is an incredibly busy and sought-after place to meet. And so we can't always meet on the third Thursday of the month. And next month we'll be meeting on the fourth Thursday of the month, and we will have a cardiology update from one of our UCLA cardiologists who is a national and international leader on the topic of coronary calcium and how that provides us information about how to triage patients for who needs the most attention. And that full circle comes back to the military, where we have the data presented at our Stanford group a couple weeks ago by the Air Force, and also from Kaiser in Northern California, where Kaiser presented about the importance of this big national study they've been involved with since 1985, of the importance of a finding of positive coronary calcium among the young. So when a person has coronary calcium at a very young age, they need special attention. And we are a learning community. We're learning together what to do about it. What the military showed is that for their very large database over many years because they were the leaders in coronary calcium screening. What they found is that a person who has a 0 coronary calcium score does not get any benefit out of being on a statin over multiple years. So a person with a 0 score has the same number of events whether they're on a statin or not. However, if you have a positive coronary calcium score, the higher that score is, the more statins help bring down the event rate. And on average, it's something around 30% reduction of events for those who are on statins. Now, we don't have a lot of details there. More and more information is coming out, particularly from the National Coronary Calcium Consortium. And we will be learning more about that information at our September 26th meeting. Welcome, Ria. Ria Pulacharam from Healthcare Partners. Could you sit there by Scott Flynn in the back, between Scott Flynn and Dr. Keith Emmons, two of our long-term leaders. So Ria Pulacharam has volunteered to work with Dr. Alan Fremont on starting a new population health work group. And thank you for presenting in June, Ria, and we're thrilled to have a full house now. So I just want to welcome Dr. Earl to the podium. And I have to say, I didn't grab the bios. I have not memorized your bio. Could we have, Carol, could you possibly read his bio while I go try to see what's going on with the slides? I'm sorry.
I'll introduce myself.
It's
kind of embarrassing.
I don't want to mess anything up.
I'm the,
Before you get started, just a quick point of information. We are in California. So everyone knows we're experimenting today. We're broadcasting this on WebEx with Jim Duddle down in San Diego. And now, as such, we are recording. And since we're recording, we're entitled to notify you we're recording this session. Anyone have any problems with that? Okay, good. Thank you.
Okay, hi. So thank you for the invitation to speak today. I'm Earl, I'm the medical director at the VA in Los Angeles, and also am a practicing internist and interview specialist. I do my interview work over at LA County, USC. So let's get started.
Megan, could you give Earl a little? Thank goodness for digital natives.
Okay, so since we do offer CME here, financial disclosures, I don't have any disclosures. I'm still hoping though. So the first slide, we have a cartoon of a patient and a doctor, both are thinking the same thing. Say, man, this telemedicine thing is great. I don't even have to put my pants on. So when I first announced to the staff over at the VA that we were implementing telemedicine, many of the staff came up to me and asked me, so does that mean I can stay home now and do my work from home? And I said, no, at that time I said, no, we're not ready for that. And every time when someone asks me nowadays whether they can stay home and do telemedicine, this slide is going to come into my mind, and the answer felt like to say, no, we're not ready for that yet. So a little bit about the Veterans Health Administration. We're one of the three main branches of the VA. The VA has three main branches: the Veterans Health Administration, Veterans Benefits Administration, and the National Cemetery. So as the Veterans Health Administration, we take care of the veterans. We're the largest integrated healthcare system in the U.S. And some say that we're the ultimate HMO. We take care of the patient from when they leave the service, which could be in their early 20s, until the end of life. So it's really to our advantage to try to keep our patients as healthy as possible throughout that time. We have over 1,200 healthcare facilities, 170 VA medical centers, over 1,000 outpatient sites of care. And that includes a clinic in the Philippines, and also there's a clinic in the U.S. territory, Puerto Rico, and Guam. And there are currently 21 million veterans, about 9 million are enrolled in the VA for their health care. We have about 320,000 full-time employees, and our 2019 budget, that's 198 billion. That was for VA as a whole. For the VHA, actually our budget was about $75 million. $75 billion rather. And last year, about $1 billion of that money was spent on telemedicine. This year, about over $1 billion will be spent on telemedicine, and next year, over $1 billion will be spent on telemedicine. So the VA is really putting a lot of resources into telemedicine. Right now, telemedicine encounters are growing about 20% per year at the VA. I think this past year, we had about 2 million telemedicine encounters. About 1 million were the video type, where we had real-time video with a patient. And about 100,000 of those were the Video Connect telemedicine product, which we'll talk about in a little bit. So over at the VA, we're the largest provider of graduate medical education. We have a lot of trainees that go through the VA. I myself went through the VA when I was a trainee. And along with being a leader in telemedicine, we're a leader in multiple other areas, including prosthetics, PTSD, traumatic brain injury, and geriatrics. So to be eligible for VA care, veterans must have served at least 2 years in the service and have an honorable discharge. There is a rare occasion where we actually take care of the spouse of the veteran too, but that's kind of unusual. The veteran population is about 9% male, 2% female. About half of our patients are 65 or over, and about 80% white, 11% black, 6% Hispanic. About half of our patients have hypertension. And from the latest data, about 78% of our patients are controlled at the JNC8 goals. And about 20% of our patients have diabetes, and the current data shows that about 79% have an A1C less than 9%. And regarding veterans who have CHF, about 2.6 veterans have CHF, and this is really an illness that has a high morbidity, high cost factor, high utilization rate. It's estimated that veterans probably, with CHF, probably they average about 2 hospitalizations per year. So why telehealth? The biggest reason, it's all about the patient. It's patient-centered. It's convenient for the patient, convenient for the caregiver. We have a society nowadays where more patients choose to live at home rather than being in institutional care. Reduced transportation costs, it's accessible. Healthcare is really moving from the hospital to the clinic to the home. And this is just a trend that has been going along throughout many years. Telehealth supports delivering the right care at the right place at the right time. And we really help coordinate care across the continuum. Telehealth may be in contact with the patient actually before they're hospitalized. Actually, they may recommend that the patient go to the ER to be hospitalized. And after hospitalization, telehealth may actually be in contact with the patient at that time, and in between clinic visits, there may be telehealth contact with the patient. So with telehealth, there's also a focus on patient education. And there's really a huge focus on having the patient learn how to self-manage their illness and also participate in shared decision-making. So also we have more patients with more chronic conditions nowadays. We have more older patients. We're a nation that's getting older. We have greater longevity, but we're also a nation that has more chronic disease. We do have better primary and secondary prevention nowadays, which actually helps us in many ways, but these things also need us to, in the healthcare field, to monitor and to try to take care of the patients as best we can. There are higher expectations in healthcare. More treatments are out there that need to be monitored. And there's actually more monitoring that can be done on a regular basis. I mean, nowadays we have Fitbits that will monitor our heart rate, our calories burned and everything. Just like that, in terms of monitoring for patients for various illnesses, there's more things that can be monitored nowadays. And also advances in technology. We do have new modalities of care. This is really the newest modality of care that's out there. We do have improved information keeping telecommunications that's available, that makes this possible. And telehealth really supports better record keeping. So telehealth is also results oriented. We'll talk in a little bit about how there are improved health outcomes with telehealth. And also one of the things that that really focused why people were pushing telehealth is that reduced utilization of healthcare resources, including reduced ER use, reduced hospitalizations, and reduced length of stay. Again, we have the ability to capture routine activity and outcomes data. That is captured routinely. And also reduce costs. We're talking about the bricks and mortar or the footprint of the healthcare industry. With telehealth, there may be a need less for infrastructure such as building, parking lots, even staffing. With the VA right now, there are about 30,000 clinical vacancies throughout the nation. And many of these vacancies are in rural areas, which is really hard to recruit staff. So with telehealth, we actually may be able to leverage this and use the staff in certain areas to deliver care where there aren't too many staff. Actually, the VA is partnering with another federal agency to try to deliver health care in more communities. Does anyone know what that other federal agency might be? U.S. Post Office. Think about that. If we could put a telehealth center in each post office, I mean, most communities have a post office, but if we could have a telehealth center in each post office, people could pick up their medication and get their health care at that time. And the VA is actually partnering with also some private entities too to improve the access to health care. Anyone care to guess what private entity might be helpful in partnering with for health care to improve the access?
Amazon.
And Amazon's close. Actually, it's Walmart. 90% of Americans live within 15 miles of a Walmart. So if we could, again, have a telehealth center at each Walmart, that telehealth center can be used for different specialties too, not just primary care, it can be used for specialty care. So that really improves the access to care. If we could have telehealth centers in different parts of the community. Also, we're talking about a reduced footprint, a lower environmental impact with less need for travel, less cars that are needed, less public transportation that's needed. Really, it gives us a lower overall footprint in our environmental impact. Let's see if this works. And this is actually from San Diego VA. This is actually when our latest project in telehealth started, is about 3 years ago.
This is a wave of the future, it's right now.
Imagine being able to get checked out by your doctor without ever even leaving your home. Well, the time has come. It's a pilot program at the VA. 10 News military reporter Hannah Mullins has why one veteran calls it a miracle.
Let's be honest, I don't think anyone likes sitting in a waiting room, but with the help of technology, you can skip it.
Dr. Stuff.
You'd never know this Air Force vet used to live on the streets.
Fine.
Charles Rowland likes to feel
My condition
and look his best.
arose from a pedicure.
Telemedicine brought doctors to him.
Thanks to the VA, I'm like 99.9% healed.
The VA in La Jolla is one of 3 VA facilities in the country doing it.
I hate sitting in waiting rooms.
And that's coming from a doctor.
Everybody's coughing and hacking.
Plus there's traffic and parking on your way in.
A lot of my patients come in with their blood pressure elevated, they're frustrated, they're stressed.
Some telemedicine patients get top-notch tools.
We have blood pressure cuffs,
They can get a reading,
we have handheld cameras,
they can see cuts and infections.
a stethoscope that the patient can place on the heart.
Yes, they can virtually hear your heartbeat.
It's fun.
This is a modern miracle.
It can't do everything. They'll still need to see patients in person at times, but Roland is at his best with time to kill.
And I am single, ladies.
And looking good with quite a good personality.
So, very funny patient. So that was about 3 years ago. By next year, by 2020, it's expected that 100% of the VAs have telehealth available like this. This was our Video Connect telehealth, where we could actually connect to patients at home.
Could you just say that again? So people heard on the video that 3 in the country had it as of that time. Can you elaborate a bit?
So the way the VA, the way that they put forward different types of technology and things like that, or spread this, is that they start with pilot sites, and there might be certain pilot sites throughout the nation. San Diego's one, I think Florida, there was another one there. And from this, they learn as much as they can from these pilot sites, and from there, they spread it throughout across the nation.
So now it is now in all VAs, or
So
it's
by
the goal?
2020, by next
2020.
year, it'll be in 100% of the VAs.
Thank you.
So I just wanted to go over and define some of the different modalities of telehealth that we have in the VA currently. From clinical video telehealth, store and forward, secure messaging, care coordination, home telehealth, and this is the project that we're working on right now, or the rollout that's going on right now is the VA Video Connect. So clinical video telehealth. This is where there's real-time video with the patient, usually in some clinic or some hospital that speaks to a clinician at another hospital or another clinic somewhere outside of that area. And this is a real-time video that occurs. It's really a face-to-face consultation that occurs with the patient and provider. And the VA has really expanded many different specialties. Certainly the bread and butter things like telecardiology, telediabetes, telemental health, tele-GI, teleprimary care. And even some of the, let me just go back a little bit. There are many specialties that are somewhat uncommon that are being used in this field too. I mean, telegenomics, teleaudiology, teledental. I mean, some of those things are being used with our clinical video telehealth. So store and forward, this is really acquisition of a picture, a video, some type of product, and it's forwarded, that's saved, forwarded to a clinician for review, for interpretation, and to be analyzed. So some of the things like Kirk Connolly, we do teleretinal imaging for our diabetics, teledermatology, where we take pictures of a lesion and forward to the dermatologist to be evaluated later on, telesleep, telespirometry, telecardiology. These are just some of the things that we use store and forward for. Secure messaging, this is really our email system. This is our text-based system where we allow patients to communicate with the clinician directly or their team, and they really could discuss issues of health, really non-urgent, non-emergent things. Patients can also send pictures and other material to us through this secure messaging. And it really allows the healthcare team to have a closer contact with the patient. With this also, patients can make referrals, can manage appointments, ask just routine administrative questions. And so care coordination home telehealth. This was our first product for home telehealth. This started about 2003, and it took about 5 years to spread this throughout the nation. And this was where we had a device where we let the patients use that was at home. It was connected to at home through a landline or through a cell phone. And we were able to monitor the patient through this device. So this device does allow the nurse to check symptoms, check vital signs, other data while the patient's at home. And it really allows a closer monitoring of the patient, and it gives us clues as to a patient that might be deteriorating. It really allows the healthcare team to be on top of things, to make changes just at that time, right when we detect things. And it does allow some of our patients to live in a facility where they would not be able to live. Maybe they live at home, whereas without this device, they might be living in a boarded care or be living in a nursing home. So this is an example of the device and some of the peripheral monitoring devices that can be connected, including a peak flow meter, glucometer, pulse ox, a blood pressure cuff, a weight scale, pedometer, a thermometer, and a stethoscope. And I wanted to introduce Joe Zavala.